a motion to adopt the minutes of the M&PA committee meeting held on February 6, 2023. Let me poll each individual member separately. Dr. Katz?
Yes.
Sally Hernandez Pinheiro?
Yes.
Ms. Pagan, yes. So next we have 3 action items for consideration. So Dr. Allen, please read the first resolution into the record and proceed with the presentation.
Authorizing New York City Health and Hospitals Corporation, known as the System, to extend its affiliation with the State University of New York Health Science Center at Brooklyn, also known as Downstate Health Sciences University, for services at New York City Health and Hospitals Kings County and New York City Health and Hospitals South Brooklyn Health through June 30th, 2026, for a total not to exceed $62,164,598, which includes a 10% contingency. The affiliation agreement between Health and Hospitals and SUNY is scheduled to expire on June 30th, 2024. H&H and SUNY have negotiated the terms of a renewal affiliation agreement with a term beginning July 1st, 2023 and ending June 30th, 2026, which will supersede the terms of the parties' existing agreement. While prior affiliation agreements with SUNY combined the academic affiliation with the clinical affiliation, the renewal agreement will cover the provision of professional services only, with the academic affiliation to be covered in a separate academic affiliation agreement to run concurrently. The total cost of the renewal agreement from July 1st, 2023 through June 30th, 2026, for a total cost not to exceed $62,164,598, which includes a 10% contingency. The proposed renewal agreement is being entered with SUNY in that SUNY is especially well positioned to continue the provision of specialty services. The services covered by SUNY include at Kings County, emergency medicine, psychiatry, and radiology for a total of 36.2 FTEs. And the services provided at South Brooklyn Health is specifically surgery for a total of 2.8 FTEs. The next slide shows the breakdown by services of the FTEs at Kings County, the majority of which are in radiology, where we have 17.5 FTEs in radiology. The next slide is a finance slide. I'll pass it over to Matt Fay to walk us through the dollars.
All right, thank you. The breakdown of the $62 million three-year agreement is presented here in the slide. It's roughly $18 million a year, rising each year with an estimated 3% adjustment for cost of living increases. You will notice that there is a reduction in the total cost of the contract between fiscal year 2023 and the fiscal year 2024. That is largely, if not entirely, a result of our splitting the relationships into multiple contracts and therefore moving the graduate medical education expenses out of the general affiliation agreement. The estimated cost of the graduate medical education is roughly $3.5 million, which represents that delta between the $22 million and the $18.2. The $18.2 would be for the clinical services and administrative costs only. If you go to the next slide, you can see the breakout in the total expenses by site, and then also looking at the base expense and the contingency itself. Kings County, the total amount is $53,276,000, which is roughly $17 million a year, in addition to the expenses associated with the FTEs that were presented on the grid 2 slides ago. This also covers roughly $475,000 for sessional coverage, additional time that's made available to Kings County by SUNY. And then also it reflects about 10 vacant positions that will have funding authority, but will not be directly funded until those positions are hired. Same too with Brooklyn. The $3.2 million is roughly $1.075 per year. And that covers the 2.8 FTEs in surgery additional sessional time, and then also a handful of vacancies that will need funding authority, but will not be funded until hired. And then you see the 10% contingency and the total NTE for the 3-year contract at 62,164,598.
So MMPA is asking approval for the resolution authorizing New York City Health and Hospitals to extend its affiliation contract agreement with SUNY Downstate Health Services University for services provided at both Kings County and South Brooklyn Health for a total of not to exceed $62,164,598, including a 10% contingency. Any questions?
I just had a quick question. Did I read that it does not include behavioral health services? I don't.
So the graph, actually, the graphic, I have a slide. It's on that slide right there. Psychiatry, 5.9
Right.
divisions.
Okay. I misread it then. Thank you.
Any other questions? Hearing none, I would like to ask for a vote. Dr. Katz?
Yes.
Salinas Espinero?
Yes.
Mr. Pagan, yes. Thank you so much.
Okay.
So your morning looks like this.
Okay.
So we will now move on to the second action item for consideration. So Mr. Wilson,
Good morning.
the resolution and
You want me to read the resolution too?
yeah, read it and the presentation. Thanks.
Absolutely. Joe Wilson, Senior Assistant Vice President of Supply Chain. Authorizing New York City Health and Hospitals Corporation, the system, to execute an agreement with Crawford Facilities Management for biomedical program management for an initial term of 8 years with 2 one-year options solely exercisable by the system in an amount not to exceed $504,327,705 for the entire contract term. Whereas the system conducted a request for proposal solicitation to manage the system's substantial inventory of biomedical equipment, including dialysis, lab equipment, chillers, stretchers, correctional health biomed equipment, IT support, warehousing of equipment, and transportation in conformance with its procurement operating procedure, and received and evaluated proposals from multiple vendors and evaluated such proposals among a diverse evaluation committee. Whereas the evaluation committee recommended award be made to Crawford as having the proposal that best meets the interest of the system, and such recommendations. Oh, sorry.
You don't have to read the whereas, just the first paragraph.
Oh, okay. All right, then let me move on.
You can move on to the presentation.
Even better.
Sorry about that.
My fault. Okay. So, New York City Health and Hospitals contract with Crawford Healthcare Services as a result of an RFP in 2014 to provide management of the biomedical equipment program. The RFP and agreement were being managed by the Office of Contract and Control. In 2017, the Office of Contract Control merged with Supply Chain. The agreement and relationship management were transferred to Supply Chain. The original scope of services was limited to repair and maintenance for 67,000 assets. Staffing and management were designed based upon the original scope, which did not build in scalability. As service gaps arose, the agreement expanded to cover other services such as dialysis, lab equipment, chillers, stretchers, correctional health, IT support, warehouse, and transportation. The Crawford Biomed Agreement is board approved not to exceed $262,214,605 for the term of the contract, and the contract expires this year on June 30th. So in the current state of the agreement, where it is only for break, fix, and preventative maintenance on the biomed side, we are really kind of limited with a smaller group of regional directors and site management who manage our unionized biomed technicians. And then in 2014, you see it only covered break fix. So there was no IT component, there was no warehouse and transportation. Many of the higher end pieces of equipment had to have been sent out to OEMs for repair. And then really one of the focus points of today is at the bottom of the slide. So in 2014, we had 67,000 pieces of equipment in the system. We now have 126,000. So we've grown quite rapidly in our inventory for biomed equipment. And then in the market overview, in general, IDNs provide biomedical equipment management services in several ways. So the alternative equipment maintenance model, which is what we use today, which is a managed service that follows different prescribed guidelines in the OEM. Some systems actually have their own in-house biomedical equipment technicians. Other facilities will use service contracts where they just do individual contracts with each manufacturer without keeping any of their own staff. And in that same model, there's other like risk insurance coverage, which is really based upon how often a piece of equipment breaks and then paying a third party as needed. Various factors and risks were considered with in-house OEM and risk insurance coverage services, including financial impact. Clinical equipment maintenance and operations is regulated by the Joint Commission and other regulatory agencies. So in the future state, what we are discussing today is really bringing 4 pillars of biomedical management services. So including our equipment and maintenance that we enjoy today and our warehousing and transportation, we wanted to add in biomed IT support. So in 2014, when this agreement started, there was no Epic, there was no PACS, there was no PeopleSoft. So our equipment now is connected to our ERP, our EMR, our digital archiving systems. And to do that, we need a different level of employee who is not only a biomed tech, but an IT tech. And then also equally as important, working on our vulnerability for IT security. So not only are we connected, but we're connected safely. And then the 4th pillar, which is very exciting, is equipment management. This is a service where they will have technicians on the floors wiping down movable equipment to make sure it is clean and available for nursing. So today we have many different models. Some facilities, the nurses or the patient care techs are doing it. Some have a third party who comes in at different intervals to do it, but it's not standardized, nor is the reporting on it. So what we want to drive here is a strong inventory system, not just for the system, but by the floor. So nursing can just go to Clean Utility, find all the equipment that they need, and not only ensure that it's clean, but it's functional. So no more picking up pumps that are with a dead battery or it has the wrong drug library. And also more time for nursing to be at the bedside and less searching. And where we talk about our little circle of life here in data-driven, this is really the life cycle which biomed is going to manage. So all the way from inspecting, tag, and test when it enters our system, connecting it through integration, PMs and repairs for its life, cleaning and tracking it while it's here, transporting and storing if needed, and then ultimately properly relinquishing the asset from our inventory. And these are the 4 pillars that we'd spoken about: equipment maintenance, biomed, storage and transportation, and equipment management. And each one of these will be driven by a series of KPIs to ensure that the health of the service is appropriate, and a reporting function as well. So with equipment maintenance, just not a strong inventory, but the ability to do wipe tests to make sure that your equipment is clean. EITS support is really tied to a direct line of reporting to Kim Mendez's group about ensuring that all of our threats are appropriately mitigated and we're tracking our activity. And then equipment maintenance is really about preventative maintenance, turnaround time for equipment, how well we are doing with Joint Commission, all of those markers to make sure that all of these pillars together are running as one uniform service. And then this is what the new table of organization will look like. So supply chain and facilities leadership want to handle the management of this. So the biomedical engineering and equipment management will roll up to supply chain and our facilities C-suite. Supply chain services will still continue to manage the warehousing and transportation, and the biomedical IT support resources will report directly to IT leadership. And just maybe to share a little bit of the reasoning for the boxes. The lower box is really showing that all of these resources are at facility level, and these ones in the upper box are reporting out to the leadership. And then our current spend. So as you can see, we are elevating this by a little bit more than $10 million a year. And that is because we are bringing equipment cleaning and management to the 11 acute cares who are going to cover the nursing floors and EDs. The trauma centers will enjoy coverage 24/7. The non-trauma centers will be more around 16 hours a day. And as you can see, we were able through the RFP to drop down even the price of the regular break, fix, and maintenance by a couple million. These other ones are fairly static. Avoidable damage is internally budgeted. Warehouse and transportation is just the market rates for the real estate. And then biomed IT support is also a new cost as well. And then for the MWB RFP analysis, prior to the release of the RFP, the vendor diversity team reviewed the program for scopes of work that might be subcontracted. Recruitment was identified as the only scope that would possibly be subcontracted. The estimated value of such work, however, was too small to set a diversity component percentage at approximately 0.1% of the contract. Accordingly, this solicitation was excluded from the MWB program. The prior contract was also excluded from the MWB program. Nevertheless, the vendor diversity team asked vendors about their MWB and CSG efforts. So one of Crawford's main businesses is actually in the food services, and their division Food Buy is leading the way in MWBE for the company. They have 450 MWBE suppliers. They have a diverse supplier accelerator program for education and mentoring and development of businesses annually, and currently has a utilization percent of 4. The parent company of Compass, first international company of its kind to announce a sweeping commitment to a 2050 net zero emissions economy. This is validated by science-based targets and further commitment to carbon neutral in our worldwide operations by 2030. They're going to transition all their fleets globally to 100% electric. We'll switch to renewable electricity across all operations. We'll ensure packaging solutions to further reduce single-use plastic, and will deliver a global deforestation-free and land conversion-free supply chain strategy. The RFP criteria, so our minimum criteria was they had to be 10 years in business, provided similar programs for multi-location IDNs with at least 100,000 biomed assets, gross sales of 75 million annually, and they had to be experienced in managing represented labor. The substantive criteria is 35% management plan and experience, 25% implementation and transition plan, 25% cost, and 15% references. And then the evaluation committee made up of many CEOs, COOs, physicians, nurses, I would say service line leads clinically had made up our group. The overview of the procurement. So the RFP was posted to City Record and sent directly to 8 vendors. Pre-proposer conference held, 8 vendors did attend. On December 8th was the proposal deadline. 3 competitive proposals received. On January 26th, the evaluation committee debriefed on vendor proposals. And on February 16th of this year, the evaluation committee completed the scoring sheets and submitted a supply chain for tabulation. Crawford Facilities Management was the highest rated proposer. The overall vendor performance of Crawford the past, since 2014 has been excellent. They were a tremendous partner during the pandemic. As we have evolved and grown our inventory, they have met those needs. As we've become a connected hospital system, they have put the right resources in place. So very happy with the overall performance of Crawford. And the request, authorizing New York City Health and Hospitals to execute an agreement with Crawford Facilities Management for biomedical program management for an initial term of 8 years with 2 one-year options solely exercisable by the system in an amount not to exceed $504,327,705 for the entire contract term.
Thank you so much, Joe.
Yeah.
Sally?
I'm trying to compare your current state with the new biomed table of organization.
Sure.
It's a little difficult to do. First, are the 2022 assets of 126,000, those were added in between 2016 and 2021?
From 2014 to today, yes.
Okay. Then the addition of the equipment management,
Mhm.
which sometimes says equipment management, equipment maintenance, but I
Well,
guess
equipment maintenance and equipment management are two different. So equipment maintenance is the break fix component. Equipment management is the wipe down and inventory component.
okay. And we're adding $10 million to do equipment cleaning and management.
Mhm.
And before we did that ourselves?
Well, so it's a little bit different at each facility. So we're currently doing some beta test, and at Lincoln, it's completely done by the nurses and PCTs, which takes time away from the patients, number one. Number two, nursing's main goal is I need to get working equipment and go to the patient. What happens is if they find a piece of equipment that's not working, it lies dormant. The ticket doesn't get opened. So we think, there's going to be a greater utilization of our equipment. And also now that we're going to be adding in like protein testing, we're going to know for certain it's clean. And because it's being managed by Biomed, which their sister company runs our central sterile, we'll know they're using the appropriate manufacturer's IFUs for cleaning, because if you clean something with the wrong solution, then it kind of can break. Other facilities have been using third parties who come in a little bit ad hoc. But I don't think we've got a uniform strategy. And I know that we don't have a uniform, like a standardization of how we do it and how we report out it, which is what we would like to do, is how often is this equipment being touched and how clean is it? And then also, what's the nursing satisfaction? We'd like to get to the point where nursing feels very comfortable that if they go to this area, they're going to get what they need and they won't have to go search.
And so you'll be keeping track of all of that data.
Absolutely.
And so on the new Biomed chart, there's 75 people that Crothall is adding for equipment management.
Yes. Yeah. That's across 11 facilities. Yes.
Wow.
And like I said, the trauma centers are having 24-hour coverage. Their EDs are very busy, so we really can't leave them unattended in the middle of the night.
Right. Thank you.
Sure.
Burketts?
No questions.
This seems very promising, and I guess it's a lot of it is on the details on how it gets implemented, right? It sounds like the kind of improvement that should decrease frustrations among nurses and doctors and so on with equipment, and allows us to know where things are and how fast they get repaired and put back into service and so on. So congratulations on that. And that was it. That was my comment.
But you're not looking to do a cost benefit. You're really looking for improved.
Well, it is, when we kind of talk a little bit about what we don't know. So if we're not really testing the cleaning of the equipment. So one of the things we're doing now is baselining and finding out how much, how much cleaner we can be. But what we are doing two betas. We are running this beta at Lincoln ED and then in Harlem on the nursing floors. And everyone seems to be extremely happy. The other winner in the department is Central Sterile. So Central Sterile, which is already kind of, reaching their bandwidth, still wipes down every one of our over 5,000 pumps and transports them. That work taken away, they're now going to be able to focus on surgical instrumentation, our new Da Vinci robotics program, and they're going to be doing more of their work. And and then the work which they don't really need to do as certified Central Sterile techs can go to this group.
Thank you.
Okay,
It's exciting.
let me ask for a vote then. Dr. Katz?
Yes.
Sara Hernandez Piñero?
Yes.
Jose Pagan, yes. Thank you so much. And our last resolution, third action item, for Divari. You can read the resolution into the record and the presentation.
How do you do the resolution? Okay. So we have Mr. Paul Muccino, who is our Senior AVP of Pharmacy and Business Operations, as well as Dr. Jeffrey Kwong, who is our Senior Director of Pharmacy Procurement Operations. And I'm Danielle DeBerry, Senior Vice President of Business Operations and Chief Pharmacy Officer. So today, Paul Muccino will be reading the resolution, and Dr. Jeffrey Kwong will be doing the presentation for us.
authorizing New York City Health and Hospitals Corporation to execute an agreement with Cardinal Health for pharmaceutical distribution and patient assistance program services for an initial term of 3 years with 2 one-year options solely exercisable by the system in the amount not to exceed $1,838,524,230 for the entire contract term. Do I read the rest of it?
No, that's it.
That's it. Okay.
Thanks. And we'll just go to the slides.
So, morning, everyone. So for the background current state, the New York City Health and Hospital pharmaceutical wholesaler has been Cardinal Health, pharmaceutical prime vendor since 2011. Cardinal Health purchases all required drugs from pharmaceutical manufacturers, warehouses them, and sells them at the health and hospital manufacturer negotiated contract pricing. Cardinal Health distributes medications and supply orders daily to 11 acute care facilities, 5 long-term cares, 5 DNTCs, correctional health, and approximately 1,700 340B contract pharmacies. It is also common practice for all hospitals to utilize a drug distribution company for the receiving of pharmaceuticals. On April 1st of 2018, the board approved a best interest renewal for Cardinal Health pharmaceutical prime vendor for 3 years with 2 one-year renewals that resulted in a total savings of $38 million. Annual current spend with Cardinal Health for pharmaceutical purchases is approximately $332 million. Cardinal Health pharmaceutical prime vendor contract expires on June 30th of 2023. For the background standardization, New York City Health and Hospital has taken this request for proposal opportunity to standardize services for pharmaceutical distribution, patient assistance program, and Drug Supply Chain Security Act software, also DSCA. On April 1st of 2018, with the board approval, New York City Health and Hospital awarded a contract to McKesson Pharmacy Optimization, also McKesson RXO, which includes Pharmacy Patient Assistance Program for our acute care facilities and DSCSA software services. The Patient Assistance Program allows New York City Health and Hospital patients who are uninsured or underinsured to qualify for a specific manufactured program drug that would allow New York City Health and Hospital to only be responsible for paying 15% of the contracted drug cost to McKesson. On average, the Patient Assistance Program saves New York City Health and Hospital $23 million a year. The DSCSA software is a subscription-based solution designed to support hospitals' compliance with the regulatory requirements of DSCSA. The DSCSA software facilitates the monitoring and management of drug safety recalls by linking customer drug pedigrees with all active recalls emitted by the FDA and/or drug manufacturers. With the current McKesson RXO contract set to expire on June 30th of 2023, a 3 to 6 month contract extension is currently in progress to ensure a seamless vendor transition without disrupting patient care. For the request for proposal criteria, there is a minimum of 10 years experience as a pharmacy prime vendor. They must maintain full-time distribution centers within the New York tri-state area, and also must have $1 billion in annual pharmaceutical sales, must have experience in online ordering platform and interface capabilities with our Epic, PeopleSoft, OmniCell, Century Split Billing, and Willow Outpatient Pharmacy Management software systems. Some of the substantive criteria includes 30% of technological capabilities, 30% cost, 20% customer support, 15% resiliency, and 5% references. The evaluation committee consists of a cross-functional group that are, service line leads and subject matter experts as well. Key performance indicators are critical in measuring and evaluating vendor performance over the life of the contract. For our pharmacy wholesale distributor, the appropriate contract KPIs include on-time daily deliveries at all locations within contracted delivery window, guaranteed fill rate and method of calculation information, product dating and guidelines adherence, and ordering and reporting system uptime. Diversity, we're gonna have Keith Taub.
Hi, Keith Halby, Chief Procurement Counsel, vendor diversity team lead. So our team reviewed this solicitation prior to its publishing. Looked at all the different scopes of work under the two main scopes that are there. So under pharmacy distribution, the scopes that were identified were logistics, services, and pharmaceuticals. Logistics is indirect spend, essentially overhead, so that's not eligible under an MWBE program because you just can't track dollar for dollar what spend is attributable to our organization as opposed to another. But I will just mention there that Cardinal does use for their long haul trucks from northern New York down to the tri-state area, an MWBE transportation company, and we are working with them to add an MWBE carrier for what they call their cross-dock services down their main warehouse downstate. The services themselves that Cardinal is providing for us under the pharmacy distribution agreement are completely self-performed, so there's no subcontracting opportunity there. And that's the same with the other vendors that perform in this space. Pharmaceuticals themselves, there's no pharmaceutical MWBE company manufacturer. On the patient assistance side of the program, professional services are all that's being performed there with some software overhead support. So all of that is 100% self-performed by Cardinal as well. So as a result of there being no MWBE subcontracting opportunity, the solicitation was exempted from the program. Proposers, however, were asked to provide information regarding their own MWBE and ESG program. Briefly, Cardinal Health has had a supplier diversity program for 29 years, which is unusual. Most companies haven't been in the market space or that program space for that long. And they focus on supplier diversity inclusion, outreach, and MWBE development. Cardinal also has a robust ESG program, including internal diversity goals, DE&I training, internal leadership and training programs, pay equity, community investment nations, climate action targets, and waste reduction and recycling.
For the overview of procurement, on August 16 of 2022, the CRC approved request to issue RFP for pharmaceutical distribution management services. On September 20 of 2022, the RFP posted on City Records sent directly to 3 vendors. The 3 major vendors include AmerisourceBergen, Cardinal Health, and McKesson, which are the largest firms to meet the volume of New York City Health and Hospitals pharmaceutical needs. On October 20 of 2022, the pre-proposal conference was held and the 3 vendors attended. On December 16 of 2022, the proposal deadline, only 2 proposals were received. And on March of 16, 2023, the evaluation committee debriefed on the proposals. On March 29 of 2023, the evaluation committee completed scoring of proposals, Cardinal Health being the highest rated proposal. From the vendor performance aspect, the Cardinal Health had a performance, an overall quality rating of excellence. So this has some of the descriptions and answers. MMPA request authorizing the New York City Health and Hospitals Corporation, the system, to execute an agreement with Cardinal Health for pharmaceutical distribution and patient assistance program services for an initial term of 3 years with 2 one-year options solely exercisable by the system in an amount not to exceed $1,838,524,230 for the entire contract term.
Thank you so much. Any questions? Sally?
Just a quick comment and a question. Well, 2 questions. Before 2011, who was the pharmaceutical wholesaler that we used?
It was Cardinal. Cardinal Health.
It was Cardinal.
Yes.
Okay. So that's just a comment. When an entity gets such a long-term contract for such a large amount and for such a critical service, then we get an extension, a 5-year extension, a 3+1+1. It just, it almost seems, we go through the competitive process and they're doing a great job, so there's no reason why you wouldn't want to continue to use them. But it feels like we're just going through the process of having an RFP and bringing other people in because they're so kind of embedded in our system. So it's just a comment that that's what happens when you have these kind of really massive, really integrated kind of services. Did either of the other vendors come anywhere close to being as competitive as Crothall?
So Joe, can you come to the table just for 2 minutes? We'll talk a little bit about AmerisourceBergen Corporation and Cardinal. And if we can also give a little bit of description about what happened with McKesson, that would help, I believe, Sally.
For just 1 second. There is an opportunity for an executive session to talk about a specific contractor's history and other factors. So I want everybody to just pause for a second and think about whether that would be appropriate in this case. Really up to you whether you think it would.
I don't think there's anything I would speak specifically that would need a kind of
little high level.
Yeah, I don't
Fine.
think.
I just wanted to.
Sure. Yeah. So without going into the details of the scoring, AmerisourceBergen had a very competitive offer. Cardinals was like, this much better, and that's why they were awarded. McKesson chose not to bid. So McKesson had issues with our RFP process. They preferred to kind of help dictate the process to us. They had asked if they could have individual conversations with committee members, and we run a very transparent process. So, they had chosen not to participate, and I had several follow-up calls with their senior VP of business out in San Francisco, and they had just said, we've made a choice that, we prefer not to bid. So we understand that RFPs are kind of costly to put together at that level, probably in excess of $1 million in their time. So they chose just not to bid. But the Amerisource bid was competitive.
And do we have our new pill dispensing machines up and running?
So Paul, you want to talk a little bit about Omnicell?
Sure. We are in the process right now of installing the Omnicells to replace the current Pyxis machines that we have. We have 3 sites that are going live now. Some of them are almost to completion, and we have the other ones scheduled to go within the next few months.
And Sally, it takes roughly 4 years in totality to roll out all of that Omnicell equipment throughout the health system. So it's a very large foundational initiative for pharmacy, but it is well underway. And these do come together over time, and you'll be able to see that as we present.
Wow. I didn't realize that. Thank you.
I had a quick question connected to MWBE, which is like when you do the assessment and the RFP goes out, right? You mentioned the patient assistance program that was 100% self-performed. I mean, why is it that they do that internally and they don't have I guess I'm trying to understand what patient assistance program is.
Sure. So it's really software. So each one of the drug manufacturers have their own criteria about how to meet that. So, financial, disease state. But what Cardinal does, they ingest all of this data. It filters through their software and it says, oh, this patient is good for this program. It's good for them. So it's not a great deal. The one-on-one comes afterwards when they speak with the patient and they ensure they come in for their visit or whatever financial records they may or may not have. But the vast majority of the work is done by the software.
Katz?
No questions.
Questions? Okay. So let me ask for a vote. Then Dr. Katz?
Yes.
Salinas Piñero?
Yes.
Jose Pagan, yes. Thank you so much.
Thank you.
So please note for the record that the Chief Medical Officer and Chief Nursing Officer reports are written submissions only. And next we will have the Metro Plus report from Dr. Schwartz.
Morning.
Morning.
So I will just focus on a couple of topics that I think are of most interest. The first one is around the redetermination resumption. It is known that close to 8 million Medicaid beneficiaries will have to recertify their eligibility for coverage as well as 1.3 enrollees in Child Health Plus and Essential Plan. All of the redeterminations, recertifications, it's interchangeable, have to be done by May 2024 in New York State. The state itself provided some preliminary estimates regarding what's going to happen with members' coverage, and you see it on the slide. So the state projections are that there is going to be a loss of over 16% in the Medicaid enrollees, an increase in Child Health Plus of about 13%, a loss of almost 11% in Essential Plan, and a significant increase in QHP. The reason there is an increase in Child Health Plus is we've seen during the moratorium that a lot of kids were moved with their parents into the Medicaid line of business. As the parents will lose their eligibility, and the state expects that children will be moved to Child Health Plus. And the reason QHP expected to increase is people who will lose their eligibility for Medicaid and Essential Plan are expected to qualify into QHP. I will mention that the majority of the beneficiaries in our QHP, also known as the ACA coverage, do get subsidies and do not pay a full premium, the absolute majority. I will also make a note that the recently, as of last week, enacted budget for 2023 and 2024 expands the eligibility for Essential Plan. So Essential Plan right now covers federal poverty level up to 200%. It will go to 250%. So that will mitigate some of the expected losses and will mitigate some of the expected increases in QHP, because more people will be able to either remain in Essential Plan or actually join Essential Plan. On the next slide, there is an unwinding timeline, as we call it. The most important takeaway from the slide is that we are in the midst of efforts to start and recertify individuals whose coverage will expire June 30th. So the first date where people will be losing their eligibility, if in fact they do not qualify any longer, will be July 1st of this year. So some of the challenges ahead that we are well prepared at this point to handle is that approximately 45% of our members will have to recertify and show that they continue to be eligible. So we're talking about approximately 45,000 members per month. Pretty significant effort. Most importantly, is that there are tens of thousands of members who have never gone through a recertification. They were new to Medicaid, so this will be the first time that they will have to go through the process. And while it's a very, very structured process, it's not a simple one, and it does require an active participation from the members. And so to be successful, we really have to take a very, very comprehensive approach and collaborate with other stakeholders.
Talia, what documents do people have to bring? That's often the most challenging.
Their income. So that's the most important.
So it's proof of income?
Yes. That's the most important one. If they are not legal residents here, and qualify as asylum seekers, or they qualify for a specific category in Essential Plan, not Medicaid, there's documentation there as well. But number one is proof of income.
Do people send it electronically to you via email, or do they have to come to bring it? How does it work?
Yeah. So there are several ways that people can do this. They can upload it through an app that's available from the state and send it to the state. They can fax it over, that still exists. They can mail it, or they can give it to us and we will send it to the state. So those are the various options. They cannot email it. They cannot attach a photo and email it. That's not allowed. everything else is allowed. Of course, the easiest way and the most common way is to take a picture and email it. That's what
Or
most,
text it even more
or
is
text it.
what most people these days would want to do it.
there has been a lot of advocacy, a lot from the plans to make it easier to provide the documents, but this remains an issue and it's not allowed right now.
So you have to contact the person and ask them, please submit your income information.
Some people know there is communication from the state as well. So there is a portion of people who will do this spontaneously on their own. Either they know how to do it because they've done this before, or they understand the instructions. Everybody else, yes, we are contacting and making sure they understand what they need to do.
I mean, having lived through these phases before, the hardest part is that if people are well, they don't perceive at the moment that they need to do it. Right. So those people who say, have a doctor's appointment, they're much more likely to do it. But the system, like all systems that are based on per member per month, kind of assumes that everybody goes, right? Not just the people who need care, right? And so you can have a situation where the only people who renew are the people with the highest costs, that the other people don't until they get sick.
That's a very valid point. 2 comments about that. It is expected that the MLR will go up because it is exactly right. We expect that sicker people will stay and will recertify, and the healthy young people will not. Absolutely. So everybody is expecting an increase in MLR. And the second one, we did look when the restarts were in place to see which population is most likely not to recertify, and it is Black young men.
And Talia, I just had 2 questions about this, if I can now. The estimates from the state, I'm a little surprised by, because I thought we would have seen the decline in Medicaid, but an increase in essential plan, especially now that's going to 250%, which you said will probably affect that number. But the QHP figure is the one that surprises me the most. And maybe it's because the income lines are so close together but to see the essential plan declining, and QHP increasing so much, it's just kind of a surprise.
You're right. I mean, essentially, once you cross the approximately $50,000 income a year, essentially, I mean, they're all kind of variables, but generally speaking, you qualify into QHP. So there's a significant population there, unless obviously they're offered coverage from their employer.
And does the state, did they give a figure on the assumed dropouts, the people that are not, of the 45,000, what percentage of them they think will not requalify, will not come into the system? Did they give a figure?
At all? So the 45,000 is our number, is the Metro Plus number. For now, nobody really knows, right? So we're looking at the state's projections. So the state is projecting approximately 16% loss. That's 16% loss. So that's what we're looking. We're hoping that we will do better than that, but those are the estimates from the state.
And the last thing I just want to say is that Metro Plus and H&H have been working like crazy on this issue together, reaching out so aggressively. Metro Plus has developed this extraordinary outreach plan. If there's a way to capture somebody, they're going to find that way to capture it. So I was at first not feeling very optimistic, but looking at all the work that's being done, I don't think we can do more than what's being done.
I agree. Part of why I was asking about the documentation is that's a part that Metro Plus can't do.
Yes.
Right. At the end of the day, somebody has to take their income evidence and send it somewhere. Right. And that can
Bring it in, which is why there's so much on the ground outreach.
Right.
Because that's someone actually sending it in requires a certain level of effort, but hopefully when you literally physically reach out to someone, that's, you know, that's going to make a difference. I don't know.
Right, I mean, to that point, so we deployed what we call concierge services at multiple locations at health and hospitals. So we have people on the ground who are able to collect the documentation. So they happen to be there or it's close to their home, they can come and drop off the documentation. So that's one of the reasons we deployed the concierge service only at health and hospitals. And the other one for now only deployed at Elmhurst is a kiosk where people can drop off their documents 24/7. And so we're seeing some utilization. It's not overwhelming, but we do see some success with people being able to access the kiosk and drop off their documents or make photocopies or whatever it is, or just do it online if they wish to. So the kiosk allows them to submit the documentation however they want to submit it. So yes, Mitch, you're right. This is the limiting factor. But we're trying to be there for the community. The other thing we're doing is community events. So we essentially did a heat map to see where do we have the largest congregation of memberships, and we actually have recertification events in the community. So you can come on a Saturday, meet our rep there, and provide the documentation, and we'll help you to recertify.
So Dr. Schwartz, we hit the hour. So is there anything you would like to highlight on the report from everything else?
I will just mention one quick additional thing from the legislative session, and that is that the quality incentive was restored. And so we're very excited about it. It was proposed that it will be eliminated. The quality is, the pool is restored to the same levels as it is today. And so there are going to be funds to incentivize providers to continue to improve quality for our members.
Okay, thank you so much. So let me thank you for your report and for all the work you're doing to make sure recertification stays on track.
Yep.
So is there any all or new business to come before this committee? Hearing none, then the meeting is adjourned. Thank you so much.
Thank you.